All right, the floor is yours, Chris.
Good morning, everybody. As Ashazar told you, my background and my only bias is that I am married to her. The fact is that gastroesophageal reflux is a topic actually that I've been involved with pretty much before I even became a physician. I was benefiting from my father having been a gastroenterologist. I witnessed the onset of the treatment of reflux back in the very beginning, the bringing out the histamine blockers like Tagamet on into the proton pump inhibitors, and so have been aware of the literature of this actually from the day they were first approved. I participated in the studies of the various acid blockers as each one came on the market. So my perspective is obviously couched in that background, but also is reflective of my personal bias as a Californian person. I tend to lean towards natural treatments and a minimalist as well. So I hope you'll sense that balance when we talk about it. So the first thing, though, we need to understand is what are we talking about when people say reflux? They often consider it synonymous with heartburn. Well, heartburn is the symptom typically described as burning sensation in your chest in the retrosternal area. Heartburn, though, is not always GERD. GERD is the condition where the stuff in your stomach comes back up into your esophagus. So again, heartburn is not always gastroesophageal reflux, and gastroesophageal reflux is not always heartburn. It's very important to look at this slide, though, and you'll see nowhere on this slide is the word acid. Burning does not mean acid, and most reflux, the sensation we think of as stomach acid, is not acid. And as people age, your stomach produces less and less acid, but people continue to treat acid and with acid suppressors and neglect to realize that a large portion of what we're considering reflux has very little to do with acid and should be treated in a different manner. So this slide here is just to give you a general idea of the anatomy and to emphasize reflux is a mechanical condition. We think of a disease, something is broken per se, you're infected by something, but in reality, reflux is a mechanical thing. It is material contained in a pocket that rolls back up where it should not. So it's a faulty valve system where the valve is failing to keep the material where it's supposed to be so it can be pushed forward through your intestines. When we talk about reflux, people often say, when should I be worried about it? Well, when should I see a gastroenterologist? When you're having some sensation of heartburn or burning, it's important we start to break down exactly what is the cause and help to direct the therapy accordingly. When we get older, if you've been having anything that you would interpret as reflux, it's worthwhile to talk to us, because after the age of 50, especially if you're a male, but women as well, white, but other races as well, nocturnal reflux, anything that bothers you, I want to know what is causing it. And we also want to look for what we call Barrett's esophagus. Barrett's esophagus, you'll hear that term, a lot of people throw it around, but think of it like a sunburn of your esophagus. In the same manner, like over your life, you've been out in the sun too much and your dermatologist is saying, oh my gosh, you're at high risk of getting a cancer because you've got all the sun exposure. Acid's been happening your whole life as well. And as you get older, the skin down there gets burned and reacts just like the skin on the outside of your body and starts to form pre-cancer conditions, which is what the Barrett's is and needs to be monitored just like the skin on the outside. Now, certain things, though, are a level higher. Alarm features, things that say this reflux probably is something we need to be more concerned about. Maybe this burn has now actually started to become a tumor or a growth. If you've never had heartburn or heartburn-like symptoms or reflux, and then all of a sudden it shows up over the age of 60, yeah, somebody better take a look. If they're looking around in your intestines and they see that you've got blood in your stool, whether you see it or not, somebody needs to take a look. If you're dropping your iron, we need to know where that iron is going. If you're losing weight and you're not working at it, that's never what we want to see. When you lose weight, we want you to obviously work at it, and we want you to have a good appetite. It's our running joke in GI that a fat patient is a good GI patient. That means your stomach's working fine. When people are getting skinny, that's our problem. Fat is other doctors' problems, like the cardiologist. But trouble swallowing, pain swallowing, change in your voice, throwing up, family history of somebody else getting a GI malignancy, all are reasons where you get our attention, and we want to be extra careful. Now, as Asha was saying, reflux is common in asthma, and they are obviously very interested in it because it is a potential trigger for the asthma. We know the presence of any reflux coming up into the esophagus will trigger one of the nerves called the vagus, which makes the reactivity in the bronchi, the lungs, heightened. It's more sensitive. You'll get more reactivity. There's also concern that you may aspirate food into your lungs a little bit that you don't notice, but makes the asthma worse. We know that people who have asthma, who take an acid suppressor, like a proton pump inhibitor, have 30% less need for their asthma medications and steroids. And that's even in people who don't realize they have heartburn. So many pulmonologists often will recommend being on an acid suppressor, but that's an assessment you would go through with the lung specialist. Now, the other aspect of it is what people hear about: reflux to the vocal cords, laryngeal pharyngeal reflux. This is where people are saying, my voice has changed. I'm hoarse all the time. I'm clearing my throat. I've got this cough that just won't go away. I have a thick feeling in my throat. It feels like something's there. I swallow, it just won't go down. My teeth, the dentist says I'm getting erosions. My sinuses, I can't control my sinuses. I'm getting sinusitis all the time. Reflux contributes to ear, nose, and throat conditions. And so we have a very close relationship with ear, nose, and throat, just like we have with pulmonary. We as GI doctors view the three areas, the sinuses and the lungs and the stomach, and as the three brothers. I tell people, think of it like you're in a car ride and you got your three sons in the back seat, and they're elbowing each other and they're fighting. And if you turn around and you take care of only one of those brothers, the other two are going to gang up on him. So when you're dealing with reflux, you have to deal with your allergies, you have to deal with your asthma. Failure to treat all three of them equally will just make the problems worse. Now, most people also understand that heartburn, reflux, as we think, is just the basic process. But some of the medicines you are treated with can bring out these symptoms and make them worse. And what happens in that situation is the pills will actually cause ulcers in your esophagus, especially if you take them wrong. Taking an antibiotic such as tetracycline or doxycycline and lying down, well, that pill will often pop right back up into your esophagus, sit there and bore into the skin like a mole. Same thing like with an aspirin, some of your medicines for your osteoporosis. And so when you are taking your medications, it's important to follow the directions they tell you. Stay upright after taking them, take them with food or drinking with water to ensure that this mechanical problem doesn't occur. And so if you notice a sudden worsening in the burning or pain or heartburn after you started a new medication, you should let your doctor know, because it could be it is causing this kind of damage and they need to stop it and treat you with an acid suppressor to get the skin to heal before it causes more significant problems.
What a,
That's a detail. Yeah, this one is also very important. People who are developing acid or heartburn often aren't having reflux. It feels like reflux. They're having trouble swallowing. They're getting the burning, but it's allergies. And people understand that food allergies, and they think of it as trouble breathing or something like that. But the most common manifestation of food allergies is a heartburn or reflux sensation. And what's occurring is when you eat that particular food and it comes in contact with your inside skin, it causes a rash. It literally makes your esophagus look like you have a rash on the outside, like you rolled in poison ivy or something. And inside the skin, there are cells called eosinophils. These are the same cells that cause asthma. They cause the spasm and the contraction, and it will cause your esophagus to try to close and make it hard for food to get through. And so being that it is a direct contact of the substance, whether you're inhaling it, sometimes it's your hay fever type of allergens, or the particular food, it's important to recognize this particular thing and eliminate the major triggers. And the most common related foods are cow milk, which anyone who's ever heard me talk knows I think cow milk is evil. Notice it's at the top of the list is evil number one. The other ones that you may notice are soy, eggs, wheat, seafood and shellfish, and nuts. And if you get a sense that these are causing your symptoms to get worse, it's important to bring it to your doctor's attention. And it may be necessary to see an allergist and help to sort these things out. The other funny thing about it, though, is if you think the food is a problem, but then you take an acid suppressor and it goes away, that doesn't mean it's not an allergy. That doesn't mean it's acid, because the treatment of this allergic esophagitis, part of it is to take an acid suppressor. It seems to block the effects. Much like putting a cream on your rash will make the rash better, but won't stop the rash from occurring. And you'll notice one other word over there under eosinophilic esophagitis. There's a newer form of this called lymphocytic esophagitis, which is a different type of reactive cell, but we've recognized that it's been occurring in the upper esophagus in people who are getting these types of reactions. And so very often you may go to a gastroenterologist and you may have seen them in the past. They may have taken a skin sample and they didn't see the eosinophils, so they ignored it. But if you look closely at the biopsies or you biopsy now, they will recognize that they missed it, that there was this lymphocytic esophagitis, which is also a form of food allergy related heartburn and reflux. Now, there are also people, though, that will get this discomfort and there's no sign of acid on all our testing, no sign of skin changes, no sign of muscle problems. And this is what they call functional heartburn, where essentially you're getting cramps. And like cramps in other parts of your muscles, they don't require acid suppression. They don't require attention on that, but they do require attention to other factors, whether it be stress, whether it be failure to exercise and stretch properly, and depression. These are the kinds of things that will bring out heartburn. And people often say, I put my troubles in my stomach. And if you're putting your troubles in the stomach and the doctors checked you and they see that there's not a lot of acid, then you might need to consider an antidepressant for something like this, or talking to somebody to help get the stress out of your body so it stops making your stomach upset. And then there are those people that also, everything looks good. Your esophagus looks fine. You don't have any allergies. Your muscles are working fine. But when we look at you, even though you have the normal amount of acid, when that acid touches your skin, you react more sensitively than everybody else. And in this situation, it's a matter, again, of trying to desensitize your system to this by other means, distraction, interspersing more water when you eat so that you won't get the contact there. But there are those who will cause symptoms that are directly related to when acid comes up into your esophagus, but it's the normal amount of acid, and it may just require alternative methods to try to get that under control. And these are where a lot of the homeopathic treatments are very effective, which we'll talk about in a minute. Now, this is one of our very common consultations, though. Somebody comes in and tells us, I've got the worst breath. Everybody's telling me I have terrible breath. Bad breath is common. Unfortunately for our patients, though, reflux is not a common cause. we've not been able to demonstrate that treatment of reflux really will have a great deal of effect upon controlling the symptom, because most of bad breath is caused by dental issues and should require a good evaluation by a dentist. The other thing is, remember the other brother, the tonsils and the sinuses. It's the drainage that often comes back to the back of the mouth and pathology within the tonsils that can bring out more of the bad breath than an actual reflux of material coming back from your stomach. And that's why we often work closely with our ear, nose, and throat colleagues. Now, moving on to treatments, this picture of a sink with food is to again remind you, most reflux is a mechanical problem. If you have a slow drain, your sink is going to back up. And if it backs up, it's going to reflux up out on the counter. You have to keep flow through the system. And even though you're eating very healthy food and good food, if your drain is not flowing, you're going to have problems. And we're going to talk first about some lifestyle things. When we're talking about reflux, obviously appropriate body weight. If you have a lot of weight, you're going to be applying pressure on your intestinal system, and it's not going to empty quickly. And when it does not empty quickly, it will back up. When you are backing up, we talk about elevating the head of the bed, trying to keep gravity, get things to go down the drain so they don't come back on up. We don't want you to wear a tight-fitting garment if you're having reflux, because again, you're pulling your stomach in. Your stomach cannot empty. Things cannot flow down the drain. You will have more trouble. Often when you get older, you have less saliva, which washes things down and keeps flow through, much like water drinking would do. And so if not a problem for other reasons, oral lozenges and chewing gum promote the saliva, will clear the esophagus, keep the acid from contacting. And think back to the people that are hypersensitive to acid. If you're chewing a gum, you're going to keep saliva flowing, the acid's going to come in less contact, and you're going to have less symptoms. And then you talk about abdominal breathing. People seem to understand that yoga and stretching is good. The thing to realize, though, that is not often explained is your breathing muscles, your diaphragm, actually run up and down the esophagus. So when you're doing a deep breathing, cleansing breathing and bringing that diaphragm up and down, it's like taking a rolling pin in the gym and rolling it down your leg muscle that's got a cramp. You're pulling the muscle straight, you're smoothing out the kinks and helping it to contract better. And so it is really an underappreciated means to keep your reflux under control. By stretching and doing deep breathing exercises, you will relieve a lot of the triggering causes for reflux. Now, substances that we've known for a long time that can bring out your acid reflux are alcohol and tobacco. They both actually cause the muscles at the top of your esophagus, the top of your stomach, where it connects to the esophagus, to relax. It relaxes you when you smoke and drink. Well, it relaxes your insides too. And when you're trying to maintain a tight valve to have the material to move forward, you are being counterproductive when you are taking in substances that will allow it to come back. So obviously, it's better to stay within guidance on alcohol intake, which you'll discuss with your doctor, and honestly, avoid tobacco. There's another problem, though, with these that people have to be aware. It's not just reflux, but right now we're suffering from a rise in all GI cancers. And one of the problems is alcohol and tobacco. They're at the top of our list. They're making all of our cancers, whether it be esophageal or colon or biliary cancer. Too much of these items is playing a major role. And we have to throw in now other substances that aren't on the list yet, but we have a strong suspicion, and that's the marijuana products. Excessive marijuana products seem to make reflux worse. They cause what's called hyperemesis syndrome, where people tend to throw up and they just can't make it stop, even though all the labels say take marijuana for nausea. That's a lie. So marijuana products, we also are seeing a lot of problem with vaping and the chemicals within vaping. So what they have touted as alternatives are turning out to be as big a problem as the initial substance. When we talk about dietary triggers, that's an interesting thing, because they often tell you, you've got to stop this food, you've got to stop that food when you have reflux symptoms. Well, there's a little part of the paragraph that they don't read you, which is dietary triggers that correlate with your symptoms. Those ones you'll improve with elimination. So obviously you've heard chocolate, caffeine, spicy foods, high fatty foods, carbonated beverage, peppermint, and that's true. They will make heartburn and reflux worse. But some people, it doesn't. And so you have to sort of use your judgment and also potentially work on portion control, which again comes back to your doctor. One caffeinated beverage in the morning, the rest decaf, probably not an issue. The interesting thing is a warm beverage will often help your esophagus clear. And they have studies that show even if your esophageal muscles are weak and they're not working well, we encourage people to have sips of warm liquid with each bite of their food, because it will propel the food down into your stomach, even in the absence of your control system, such as if you'd had a neurologic issue and you want to get your esophagus to clear, warmth is better than cold. When we talk about acid suppression medications, there's a lot of press and internet talk about these things. The two main types are histamine receptor antagonists, that's the classic Tagamet, Pepcid, things of that sort, and then the proton pump inhibitors, omeprazole, esomeprazole, pantoprazole. These are all, there's a wide range, and the companies, the insurance companies will contract with one or the other, and you'll be switched back and forth. As we go on to talk more about this, it needs to be understood that these medications have been used since the mid-70s. And when they are attacked, there's often attacks in the press that are fighting like a salmon upstream against a lot of long-term data that shows their usefulness. Recently, Neurology put out yet another article that talks about proton pump inhibitors making people more likely to get Alzheimer's or have trouble with memory issues. When you hear about the risks of long-term proton pump inhibitors, they're going to say higher risk of gastric cancer, higher risk of intestinal infections, higher risk of osteoporosis and bone fractures, higher risk of renal failure, higher risk of liver failure, higher risk of Alzheimer's. Notice the question mark next to each of those. Every time they come out with one of these studies, they tend to have to back off. We've been using these for over 40 years, but we really don't see this huge rise in any of these conditions. Often the studies are flawed. They're taken out of a population which has a high risk of all of these conditions occurring. And then they use statistics to show that maybe this use of this medicine nudges it a bit higher. It's often a way for a physician to get a reputation, to come out with something that would say proton pump inhibitor use is a danger. And it does a disservice to people who really need them, because they do have very significant benefits, as we've been talking about. The use of acid suppressors in the right population will help to prevent pre-cancer changes and potentially advancement to cancer in that region of your body. Definitely, it prevents scarring. Anybody who's had food become stuck in your esophagus, whether due to a Schottky ring or a stricture, knows that is a really obvious thing that you don't want to ever happen again. It's an ER visit, it's pulling the food out, it's stretching, it's very unpleasant, and you can't eat. acid suppression, since we got this now, we didn't have acid suppression early on in my career of the nature we have now. People who started to have food become lodged in their throat would have to dilate often at home. They would buy their dilators and they would go to their kitchen whenever they felt something was stuck, sit in a chair and dilate themselves like a sword swallow. Since starting these acid suppression, we dilate them once and they never come back if they keep taking it, if, in the vast majority of people. Or if they do come back, it's very easy to open it up again. So obviously in certain populations, these medicines have been a game changer. We talked about asthma, how acid suppression can significantly reduce your ER visits and use of steroids and your inhalers and make control of your asthma much easier. We talked about sinus issues, the chronic sinusitis, the tonsillar issues, the voice changes. These people obviously, those are significant problems that acid suppression will help and should be a conversation you have with your ear, nose, and throat physician. And coming back to trouble swallowing, it doesn't just have to be scarring or blockages, swallowing in general. When acid strikes your esophagus, it causes it to spasm. So you're trying to swallow and all of a sudden it just stops or it comes back up. It's an unpleasant sensation. Acid suppression will often prevent that. So when we talk about any treatment that you receive, we talk about risks and benefits. And you, as the patient, have to be a part of that decision. Obviously, clear benefits in certain situations, and your doctor's going to tell you this medicine is helping you because of this reason. These risks they talk about, the risks of Alzheimer's, kidney, liver, whatever the problem of the week is, have not been clearly demonstrated to be a significant risk. And when you take any medicine and you look up in the book, the risks of taking that medicine, they're always scary. But if you have a clear benefit and that risk is rare, it's or a perceived risk versus an obvious benefit, it obviously makes sense to take the medication. Now, in other situations, like heartburn, where you don't necessarily have the highest risk, it comes down to the obvious. Take the least amount of medicine necessary to control your problem. And if you don't want to take the medicine, well, you've got to work the lifestyle factors that we were talking about a moment ago. Because if you can improve your lifestyle, drop the weight, eat better, you may not need it. And that's fine. Then you reduce any of that potential risk. Some people discover that if they do things right, they only need it when they go out for that great dinner or that wedding. And they know they're going to be having that big steak and they're going to have that drink that night. Well, then they take their acid suppressor an hour before that situation and protect themselves from that situation. Because on the other days, they don't need it. Those are acceptable use. But the idea is tailoring the use to your need is important, and not to stop taking a medication that has a significant benefit to you without a conversation with your physician, first of all, and sometimes not just your physician, but your gastroenterologist, because there will be a difference of opinion sometimes between your internist who read the study that you read about Alzheimer's and perceived risk versus a gastroenterologist who knows why you're taking it. Now, when you are on acid suppression, people are often concerned about vitamin absorption. Honestly, we don't see that as a major factor, but we all need to be very good with our vitamin supplementation and working with our primary to make sure we're providing our body with the proper vitamins we need. The three that people are most concerned about with an acid suppressor are magnesium, calcium, and B12. And these are ones that you should be being checked anyway, and ensuring that you have adequate supplementation if necessary. Now, when we talk about natural products, again, we're in California, people are going to often come to you and say, you don't need that one. I've got the stuff for you. Very often, though, you have to read very closely what's on the label, because they will often be repackaging of Tums or Melanta or a natural version of it. Sodium bicarbonate is always a major part of these things. And The other thing that they tend to do, though, is they tend to put a fair amount of sugar or sodium in these. And those can be a factor if you're a diabetic or you have blood pressure issues, where somebody is giving you 6% of your daily value of sugars on your acid supplement. That can be a significant amount that your body has to deal with. And so read your labels, bring your products to your physician so they know what you're taking. Be careful about products that overlap with what they have in them. You may be taking them for one purpose, but there are other ingredients that they're not emphasizing could be increasing your dosing of another substance you're taking and causing you to reach high levels or even toxic levels. So those are things is when you're taking supplements, make sure your doctor knows which ones you're taking, which brands, what's in them, so that you're careful not to have duplication, especially where not necessary. Now, many people often use as a natural product, though, the apple cider vinegar. From our perspective, we think that is generally harmless and when used correctly, like anything. And if it helps, go for it. I actually tell my patients to try it because it often is very effective at keeping the sensation away and supplementing any other treatment that we're doing. So I have no problem with that at all. I've run through this fairly quickly, but I hope that if there's questions, I can continue to provide information that's of interest to what you all would like to see. So we'll open up to questions, and if not, I can also free-form talk a little bit more as well if needed.
Well, I'll jump in first. I thought, for all of you, Chris and I did not collaborate on it. So a lot of the messages I provided, he did on his own. And so I was glad to feel reinforced. The supplement, I was circling grapefruit seed extract. Many people are on statins. And so with your supplement for reflux, you've just negated your anti-reflux medicine, since grapefruit and Lipitor can't be taken together. So just keep that in mind. So something as minor as that can play a big role in your other medicines, as Chris was saying. We've got a question in the chat. What is correct use of ACV? Matters if is it raw or not?
What is ACV?
What is ACV?
I think it's a form of vegetables, cruciate vegetables.
Apple cider vinegar.
Oh,
It's already got its own little initials.
Generally, the major issue with raw versus pasteurized types of any product is the concern about source and contamination and infection. I actually have no problem with raw or other forms of it, as long as you're careful of your source and it's a reputable company. And so in that regard, I tend to lean towards wanting the more natural product, but that's my one caution.
Are there any other questions?
If not, I've got another couple of things I wanted to say.
Go ahead.
And so talking also back about the mechanics, remember that other factors that I didn't make slides on that I left out is to realize, again, to emphasize, acid production declines as you age. So your stomach lining starts to gradually atrophy. And so what you've been doing for many years may not be the same thing you need to do as you get older. So having been on an acid suppressor for a period of time, should, even though you're in good control, there's consideration at some point of doing a trial of reducing the dose and seeing if a lower dose or every other day will still be sufficient. Always done in consultation with your physician, because at some point with the atrophy, you may not have very much stomach acid at all, and the medication may be doing very little. The other general thing I would leave you to think is also, as we said, mechanical. When your stomach is trying to empty, especially when you're not as active as you once were, cooked is going to be better than raw. Soup is going to be better than salad. If the food is moist, if the food is properly chewed, if it is broken down a bit, then your stomach can empty it quicker. If you're eating huge salads at dinner, you're very likely going to reflux all night long. Salad, if you like salad and you really are going to do it, it should be a lunchtime thing, not a dinner thing. You've got to think when you are processing anything that takes a long time to chew is going to take a long time to get out of your stomach. The other thing to be aware of is people who are not sleeping well. This often can be reflux related. Classically, at about 2 o'clock in the morning, your stomach goes through its natural cleansing in which it releases acid and resets for the next day. Very often people will also notice, I come awake at 2 o'clock in the morning. Sometimes I even have to sit up on the side of the bed. That is not your imagination. That is the acid bursts occurring. And if your stomach has a lot of raw material from earlier in the evening, you're going to reflux because you're lying flat. And that's part of what we're talking about, mechanics, elevating the head of the bed, making sure that the food items you eat will exit your stomach promptly. We prefer you not go to bed until 4 hours after dinner, minimum. And so these are all ways to promote forward movement through your intestines as opposed to reflux or backward movement back towards the mouth. Those are, oh, and one other aspect of it, and again, it's my common thing, moving your bowels. If you're not moving your bowels every day, where's the food supposed to go? Your stomach wants to empty and not reflux. But if you haven't moved your bowels in a couple of days, there's no space. And so it's going to send a message to your stomach, hold it up there, keep it up there until we're ready for you. And that is going to promote reflux, especially if you try to lie down. So moving your bowels every day promotes gastric emptying, obviously, because they are the same tube. If the bottom of the tube is clogged, the top of the tube is going to back up.
So we received a thank you for the Alzheimer's information. Chris is available for a few more minutes if you have any questions. But I guess you must have covered everything because there aren't that many questions. So if they come up, you just let us know or email and we'll address them. But thanks, because I know you have to go to the hospital.
Take care.
So thank you all for 40 minutes of your time this Saturday. I'm going to stop sharing this and we are going to switch to another topic. Let me see if I can find my other slides that I've got ready. It's not coming up here. So let me see if I can get it up. There it is. So while I have your attention for a few minutes, I've been getting a lot of questions this week on vaccines. I've also been getting a lot of, we're done with vaccines and that's totally okay. Please don't think this is a push. This is more a conversation on if you have these questions, how to address them and how should we time things. As you know, I'm not a fan of getting multiple shots all at the same time, but the CDC would like you to. Here is the 2023 adult immunization schedule, and we try to keep everybody up to date. I put a red near the ones that are currently seasonal for the fall. There's COVID vaccines, there's the influenza vaccines, there's a new vaccine for respiratory syncytial virus, RSV. And then we have some folks need to catch up with their pneumococcal vaccines as well. So these are the ones that I'd like to discuss just a little bit in terms of a timeline. So we've all received our COVID vaccines, and some have received 2, some have received 5, and some by accident have received 7 shots. Um, and we all know that we haven't been able to keep up. We, as in the House of Medicine or science, has not been able to outsmart the virus and predict how it's going to mutate. And so our vaccines are a little bit mismatched in terms of what's in them and being a complete match to eradicate the virus. So the virus continues to outsmart any human host or vaccine that's been created. The current COVID booster, which came out last September, is still the one on the market. It's against the original strain, BA4 and 5. Well, we have Omicron that is circulating, and now we have EG5, which is a subvariant of Omicron. That booster doesn't come out until late September, October, which may mean that the current wave, I'm seeing a ton of COVID right now, may have passed and people will have a natural immunity. We'll see. But if you are anticipating you're traveling right now or going to go to a wedding, say next week, and you're under immunized, you may wish to just give yourself a little boost so that you don't get as sick as if you aren't immunized and if you've never had COVID before. Otherwise, some people are just skipping this, and that is your comfort level, depending on your reactions to prior vaccines and your thoughts about the vaccine. Because remember, these vaccines only last about 12 weeks of protection, 3 months. So you have to time that a little bit to the new vaccine coming out. So that's a lot of considerations. There's not a yes, get the booster advocacy going on right now. And it's I'd say it depends. If you're immune compromised and you want that little extra protection, make sure you're caught up. Now, the flu shots, they just hit the streets last week. Rite Aid has them and is calling folks in, I understand. I recommend getting it by the end of August, early September. We're anticipating an early flu season based on what happened in Australia. So what happens in Australia's flu season during our summertime is their winters, it comes here. And we historically follow that path. So last year we had an early flu season, and this year it's anticipated the same. And what's happened now is a trend that by October, the pharmacies have been running out of the senior flu shots. So the early bird definitely gets the worm. So target late August in the month of September to get your senior flu shot. Regular flu shots are available throughout the whole winter. But we ran out, I think, last February. So plan on getting the senior flu shot coming up. And then the month after that, October. Last year, we had a big RSV season once the kids went to school. And so there's a new vaccine for respiratory syncytial virus recommended for folks over the age of 65 who may be immune compromised, exposed to congregate settings or places with lots of children and where you mix it up. RSV tends to lead to asthmatic-like symptoms and post-viral pneumonia. And this is the first of its kind being offered to adults to help minimize respiratory infections. And so I'd time that for after your booster, or you could flip-flop and get the RSV first and then the COVID booster if you want it, depending on what you did here. So that's the timeline that I advocate for. And now let's switch gears and talk about what I don't know if it's on all your minds yet, but I hope it is. We've got a hurricane off the coast of Baja traveling up north this morning. They anticipated that the winds will come earlier than Sunday and will start today. I checked the weather app. We're going to get rain around 4 o'clock today, and then starting at 3 a.m. It's already cloudy if we look out the window. Um, we don't know what to expect. The word catastrophic is being used. So I don't, they may actually have rolling power outages if the winds are strong so that fires don't get started. So anticipate some temporary power outages. That's what I'm getting from the state reports. So have flashlights ready. Just some spare water, fill up some pitchers of water just in case our water supply gets interrupted. Make sure you have your medications. Who knows if you get flooded and you have to, get rescued. Make sure you have extra batteries and your phones are charged up. My landline, I've got plugged in. I keep a landline with an old fashioned dial phone. So if you need me, apparently there's, even if all the power is shut out, there's this teeny little electric current for 911, and that keeps landline phones operational. Um, and just make sure you have some food for a couple days. I've been placed on alert for our California disaster medical teams, so the state is closely monitoring this. So I thought you should all know. And that's it. I am going to stop recording right now once I find the button and we can have a conversation answering all your questions.